We're going to dive into the thyroid glands, and then we're going to move to the pancreas. Okay, and that's going to wrap things up. And again, the disclaimer, the caveat is this is in no way, shape, or form the entire endocrine system. But again, this is like endocrine disorders in 2 hours, right? So I mean, like most of the units that we cover, we barely do it justice by scratching the surface. But some of them we can go in depth enough. It gives you, I think, some of the mechanistic understanding so that as you move on in your studies, you'll have the ability to relate to some of the details that we haven't had the time to talk about. So in the world or in the family of thyroid glands, you know, a really scary picture is always the best. So I was talking with my daughter about this lecture. So my second daughter is 12, and she's heavily into ballet. This is the year that she goes on point. And she's been training, I don't know, she's 12 and she's been dancing for like 6 or 7 years now. And the last 2 have been pre-point, where they just train your feet and your ankles on how to get ready and all that. So we went and bought these like ridiculous pieces of fabric with wood in them. They're made by this old grumpy guy in Phoenix, and he's the only person that makes them. And so they're super expensive, and they're supposed to last like 3 months. I'm like, oh my God. Really? I thought running shoes were expensive, right? So these like ballet on point shoes are just as expensive, if not worse. So anyways, long story short, she used to sit in the back of these lectures probably about 5 years ago, because my wife and our schedule lined up where I took her to ballet right after lecture. And she says, I don't remember many of them, but I remember this one, because I was getting ready for a lecture this weekend, and she saw this picture. She's like, I remember that guy, because that's like a really disturbing picture for a little kid to see, right? And this is a little kid. So this young boy is suffering from hyperthyroidism, thyrotoxicosis, where we've got a sort of disease of the thyroid. Now, primarily or secondarily, we can end up in this situation. So from a primary standpoint, that means that it's really something wrong with the thyroid, right? Primarily, or a primary hypothyroidism would be there's an overproduction at the level of the thyroid itself. So one possibility for this young boy could be Graves' disease. And I promised you that we would talk about this. And this is where some of the immunology comes in, because Graves' disease, to refresh your memory, is a hypersensitivity. Do you remember which class it was? Type 2. Very well done. Type 2 hypersensitivity. So do you have to know that for Monday? Yes, you do. Okay? You need to know that one because it's related to the thyroid. Okay? But the class builds on itself. So I want you to see where the themes come back in and out all the time. Inflammation being the biggest one. But here is hypersensitivity type 2. So in Graves' disease, you're making antibodies. These are autoantibodies to the thyroid stimulating receptor that's on the thyroid, and it makes them active. So even though you're not getting TSH from the more TSH from the anterior pituitary, the antibodies are triggering the receptor to make thyroid hormone. Okay? Or you can have a single or a multi-nodule lesion on the thyroid, which is very common. In the example of one of my close friends and my father-in-law, they both have kind of the same thing. They have lesions, multi-nodule lesions on both sides. If it's only on one side, they might remove one lobe of the thyroid and leave the other. And then a lot of times in those cases, the remaining lobe takes over the production, and you don't need to have supplemental thyroxine. But if you take the whole thing out, you have to. Or the third example of the primary could be just an adenoma that's sitting there, not a nodule, but an actual tumor lesion that's taken over the thyroid, and it's producing functional hormone. Now, the only example of secondary would be hyperthyroidism, where you get overproduction of TSH from the anterior pituitary. So in this particular patient, you probably have the picture, so you see what he looks like. But this is taken July 7th, 2008, and this is actually December 29th. of 2008, right? So this is not even 6 months later. And you can see the restoration of this young boy. And so the scale bar is this little necklace that he's wearing. You see the little necklace, right? If you need a scale bar. But it gives you the relative increase in size, because in hyperthyroidism, like with Graves' disease, you get this overactive thyroid, so you have a high resting heart rate, high metabolism, difficulty sleeping, lots of weight loss, right? The thyroid is going too fast. And the treatment in this particular case was actually, instead of surgical removal, this patient actually used thyrostatic drugs. And the one that was used in this patient was carbimazole, C-A-R-B-I-M-A-Z-O-L-E. It's a thyrostatic drug which actually kills or targets or poisons the thyroid. Okay? Some more details about Graves' disease. We've mentioned it earlier. Again, a type 2 hypersensitivity. The picture that's here is actually a very rare side effect, a very rare symptom of Graves' disease. About 1 to 4% of the population that suffers from Graves' disease actually has this pretibial myxedemia. This is a derm pathology where they get this redness and inflammation of their lower limb extremities. But the other clinical features that you see more prevalently are going to be hyperplasia or hypertrophy of the thyroid itself. So they'll get sort of a bigger swollen thyroid gland in their neck. And then they get this classic eye disease. And of course the weight loss. This classic eye disease that we look at is called exophthalmos. E-X-O-P-H-T-A-L-M-U-S. Exophthalmos is this eye disease that's classic, kind of this bulging eye syndrome in Graves' disease patients. This is the same picture that we looked at in our hypersensitivity lecture. I've just reinserted it here so you kind of appreciate this is a thyroid epithelial cell. These are autoantibodies that target the TSH receptor and they stimulate it. As they stimulate it, it produces a response that triggers the production of T3 and T4. Okay? So these are the clinical manifestations of Graves' disease: increased basal metabolic rate, increased heart rate, weight loss, the bulging eyes or the exophthalmos, difficulty sleeping at night. I think I said weight loss, right? And then the opposite is hypothyroidism. This is the most common malfunction of the thyroid, is hypo, not hyper. So in hypo, we've got our list of primary versus secondary. Primary meaning things that affect the thyroid itself. Secondary are things that are unrelated to the thyroid but actually influence it as a downstream effect. So an autoimmunity, where you've got anti-thyroid antibodies, our first primary example. We've got a bacterial infection, thyroiditis, or we've got an endemic goiter. The endemic goiter is where patients don't get enough of dietary iodine, and so the thyroid itself enlarges because it needs iodine to function metabolically. And so when it's starved of iodine, it actually enlarges to try to compensate for the inability of that tissue to work. So it tries to enlarge and make as much as it can, and that creates this endemic goiter. We don't really have that problem in this country. It's more of a third world issue. The United States government began working in the Great Depression time, in the early 1930s, to basically prevent endemic goiters from happening in the United States. And so they added it to a supplement that all Americans seem to love. Okay? We can't get enough of it. And then it ensured that we wouldn't have a lack of iodine. Do you know what that? Salt. Iodized salt. Okay? Seemed to work. Okay? So if we could figure out a way to put anti-cancer therapy in Big Macs and French fries, we've solved our problems. Okay? Well, we've introduced some new ones, but we've solved our cancer problems. Okay. So worldwide, 90% of goiters are due to iodine deficiencies worldwide. Okay, if you take the United States out. Foods that are rich in iodine, seafood like tuna and cod, seaweed, eggs, and milk. So these are expensive foods to come about. They're not inexpensive food in the global economy. And so that's one of the reasons that you see it more of an issue in third world countries. In adults, it causes mental sluggishness, right? So that untreated patient looks sluggish to me, just staring at her, right? And then the thyroid hormonal therapy is what you're seeing over here, and that's usually a pill once a day for thyroxine, usually is what they'll give. Other types of issues other than goiter would be like anti-thyroid drugs, like the carbimazole. If it goes too much, right, it creates a lesion that's too big. Secondarily, sort of a side effect is you could have had a congenital abnormality. And I'm going to show you an example of that congenital abnormality here in a couple of slides. So a congenital abnormality would be a secondary way that the thyroid would be influenced. Or if you had hyperthyroid treatment and you surgically removed it, like an example of my close friend and then my father-in-law, then they're going to be hypothyroid after you remove the thyroid because they were hyperthyroid first. Make sense? So, a Japanese physician, Hashimoto Hakura, first described this disease where you've got attacking of the thyroid by your immune system. So this is the first one on the list, the autoimmune. And so Hashimoto is the most common type of hypothyroidism that's related to autoimmunity, Hashimoto disease. And so you can appreciate from this slide that you've got the generation of helper T cells and the production of this subclass of helper Ts that activate macrophages, helper T cells that activate your cytotoxic T cells, and then also helper Ts that create autoantibodies targeting specifically the thyroid epithelium. All three of these pathways destroying the thyroid tissue. And so this was first, this is kind of a funny story, but Dr. Hashimoto from Japan, he was at the Kaishura University, and he first described this in a German publication. I know it's kind of weird, but I just wanted you guys to see that. It's very international. Still has his name after it, hasn't lost that, and so I'm giving him credit where credit's due. All of this activity really focused on the sensitization of a helper T cell, right, a CD4 positive helper T cell, to the patient's own thyroid epithelium. Okay. But because it involves T cells, this would be really a type 4 hypersensitivity, right? You have antibodies being produced, but still it's type 4 because you've got T cell involvement. The congenital example that I spoke about is shown on this slide. So in this slide, we've got an untreated patient on the left, and then you can see her on the right, much happier, right? You can tell by her face and her smile. So in kids, we call this congenital hypothyroidism creatism. And these patients have a lot of the same side effects or clinical sequelae that are associated with hypothyroid in adults. You've got low basal metabolic rate, mental sluggishness, they gain weight, they have edema, their GI motility is compromised, so they're constipated. They'll actually develop pericardial effusions that surround the heart and can lead to conditions of early heart failure. Without a lot of energy and without very much perfusion, they become very cold intolerant. So they're cold all the time. The treatment of this congenital thyroidism is actually giving T3 or T4, and you can take a patient from the left picture to the right. So I want to give you some examples. This is a 10-year-old female with severe primary hypothyroidism. Before treatment, she was relatively obese for her age and her size. At age 10, she hadn't lost a single baby tooth. She hadn't lost a single deciduous tooth. And she lost 6 teeth in 10 months after treatment. She had striking catch-up growth. Her bone age was 5 years at a chronological age of 10 on this left picture. So after treatment, she caught up remarkably. But I can't imagine this 10-year-old little girl had not lost a single baby tooth. But the development was just super, super behind. Okay? And all it took was a little thyroxane every day, and this is what my daughter has. Now, obviously, we were kind of on top of it and paid very close attention to it, so it wasn't that aggressive. But the trigger for us was the pediatrician was realizing that my daughter was falling off on the growth charts. So she was getting lower and lower percentage on height. And she wasn't heavy, she just was small. And so they wanted to test, endocrinology-wise, they wanted to test is growth hormone an issue, and as they tested the panel, they found that her thyroxane levels were low. And of course it was a little scary because we didn't know if there was a tumor in the brain, but it turns out she has congenital hypothyroidism, and she might grow out of it. So we'll have to just keep track of it, okay? But yeah, she takes this pill, and she's short. My wife is short. I'm really tall, but my wife is short, so that's where she gets it from. And so that's what I told her. I said, I have big ideas in my mind, so I must be tall. But yeah, she's not going to be huge, right? But this is one of the things where you know some of these things, and it applies to your own family. It makes it very, very real. Okay, I have a question here. When we were going through this, turns out that the primary way to diagnose my daughter and this patient here is going to be on TSH levels, thyroid stimulating hormone levels. Now, why is that? They see all of these issues, and then they measure TSH. And why is that?
Is it because if the TSH levels are normal and low, it must be a problem with the thyroid?
That's right. And so if they're not normal and they're high, let's say they're high in these patients, right? Then the body's trying to increase thyroid hormone by increasing TSH levels to compensate. If they're low, then it's likely that the thyroid's going to be overactive. And they know that the thyroid's not overactive, right? So that's why they go after all the panels. They'll kind of focus on TSH to see what's happening at the level of, not the thyroid, but from where? Where's TSH come from? Posterior or anterior? Anterior pituitary. Very good. Okay. So our last target tissue that we're going to talk about today is the pancreas. And the pancreas, we're going to highlight diabetes mellitus. So diabetes insipidus was siphoning off taste, right? Diabetes mellitus, I think actually would be a great name for a little girl. But my wife's going to go for it. Because, no, listen, so maybe just mellitus, okay, not diabetes. That's got a bad connotation, but nobody knows what mellitus means. Mellitus means sweet like honey. Aw, wouldn't that be a great name for a daughter? Don't you guys think so? I'm done. I had 4 and I didn't use mellitus, so it's still available. It may not be like, 2017's top name for a little girl, but I think it's so sweet in the Latin, mellitus, right? Hey, mellitus. So I try to use it around the house as like, thanks, mellitus. Like, thanks, sweetie. Get it? All right, maybe it's not so great, but I like it. But now you won't forget it. Sweet like honey, because if you smell the patient's urine, I guess if you tasted it, if you're that kind of doctor, it would taste sweet. Because there's too much sugar in the blood that actually gets filtered into the urine, and the urine has a sweet smell to it. Okay? Diabetes mellitus. Now, insulin. Insulin is at the core of the slide. You can see that insulin has activity on 3 different target tissues. Adipose tissue, striated muscle, skeletal muscle, liver. You can see in adipose tissue, you increase glucose uptake. with insulin. You increase lipogenesis. You decrease lipolysis. At the level of skeletal muscle or working striated muscle, which would include cardiac, you increase all three of these: glucose uptake, glycogen synthesis, and protein synthesis in the presence of insulin. And at the level of the liver, you decrease gluconeogenesis when insulin is present. That's the production of new glucose from scratch. You increase glycogen synthesis because you're storing the excess glucose. And you increase lipogenesis, or burning fat. Producing fat, storing energy in the form of fat. Lipogenesis. So when we look at complications associated with insulin, we've got either a type 1 or a type 2 phenotype. The type 1 is the inability to produce insulin. It used to be called child onset, but that's not a great definition anymore. Because we're seeing patients present with type 1 diabetes later and later. I told you the story, the funnel cake story. You guys remember the funnel cake story? Okay. If you don't remember it, shame on you for not coming to my lectures. No, it's on YouTube. But this is a family friend who basically had like one too many funnel cakes at a state fair, or not a state fair, but at an amusement park, and actually went into a coma. And this was like a super healthy basketball star in high school. And he was like 18, and then he, went into a sugar coma, literally. He had blood sugar levels over 700. Or type 2 is an inability to respond to insulin. And type 2 oftentimes is followed by B-cell dysfunction. B cells or beta cells are the beta islet cells of the pancreas that manufacture the insulin. And then the third category would be pregnancy diabetes or gestational diabetes. That affects about 3 to 10% of the pregnancies. I actually have a close colleague who is pregnant, and she has gestational diabetes, so she has to be very, very careful. There's no specific causes that we know about gestational, but it's believed that the hormones during pregnancy increase the woman's resistance to insulin, leading to an impaired glucose tolerance, likely to make the blood flow from the mother, the maternal blood flow, more rich in glucose, so that the the fetus actually can extract more glucose in fetal circulation. That's the theory. Okay? Yes?
Does the gestational diabetes go away after the...
Usually it does, or it subsides to a level that's much more calm. Birth weights of gestational diabetic mothers are much, much higher than normal birth rates. So they're like 10 pounders plus. Like, ooh, yeah. That's why there's like a lot of like focused energy on the mom to take care of the diabetes. She doesn't want to give a 10-pound baby birth. Okay? And these are, some of these women are really small ladies, and they're having like 12-pound kids. Yeah, I know. You're like, that seems messed up. Okay, no. Okay, so this is a new slide. I actually put 2 new slides in here if you just want to read down the lecture. I'm just going to speak to them. But they're on the PowerPoint that's posted. They're on the video. So how do we diagnose diabetes? Well, we usually can do it with a blood draw. So we'll do normal glucose levels are somewhere between 70 to 120 mg per deciliter. In diabetes mellitus, and you can kind of see these graphs here that I added, you can have one of 3 situations that will lead a diagnosis to be diabetic. One is over 200 mg per deciliter on a random draw with symptoms, or a fasting glucose that's over 126, meaning they haven't had a meal, like when you first wake up in the morning before breakfast. Don't you hate that when you have to get blood drawn, you're like fasting, right? And then you have to wait for like an hour and a half, and you're like, oh my gosh, I haven't eaten. I'm one of those guys. I get really grumpy when I don't eat. So, like I take my food with me, and like right after they pull the needle out, I'm like slamming crackers. They're like, I gotta put your arm up above your head. I'm like, all right, I'm eating with this hand. So fasting glucose of 126 mg per deciliter or higher, or an abnormal glucose tolerance test. So a where they give you sugar, and then they measure what your response is in the blood some period of time later. So you kind of see these charts here that I pulled. So this is sort of our normal response after we might eat something. Maybe this peak would be a little bit higher in some of us. Pre-diabetic is going to be super, super in between, right? And then the diabetic is, kind of a big curve response. Another graph that I added is on this slide. You can see, this one I like because it shows it over the course of the day. So we'll start at night. You can see the little moon. You can see at night our glucose levels drop as we sleep during the night. And then our fasting levels, right? And that's why you take a fasting blood draw early in the morning before breakfast. Because as soon as you have breakfast, look at what happens to your glucose levels. And they come down, right? And then you sort of get this little peak right here. What is this little peak responsible? What causes this little peak sort of like mid-morning? It's not a snack. That's that might be what happens to me, but right? That's your Hobbit breakfast. That's your second Hobbit breakfast. No, this is your body trying to keep this from dropping, so it breaks down glycogen and floods the system with more glucose level, right? And then as it drops, and you get, Dr. Kelly is super grumpy. Then you have your meal. Comes back, here's your afternoon Hobbit snack, or glycogen coming available, and then here's your dinner, and then, like before bedtime, and then this tapers off. Okay? So this is normal situation. You can see the levels of like 126 here. So in the mgs per deciliter, if we go back a slide, you're going to start to appreciate that the 126 is pretty high for a fasting level, right? Because our fasting level should be down in the 70s. Okay? So if we look at the pathogenesis of type 1, pathogenesis of type 1 is an autoimmune disease. We have a hypersensitivity reaction. What kind of reaction is type 1? Hypersensitivity. Type what? It's not a type 2. It's a type 4. Why is it a type 4? T cells are involved. Okay? Are there antibodies that can get involved? Yes. But because there's T cell involvement, then it automatically pushes it into a type 4. Okay? So it's not really that you're totally wrong, you're just half wrong. Okay? Just being honest. So we've got CD4 and CD8 cells that are involved. It's an inflammatory response. You get B cell involvement, which is probably what threw you off on the type 2. But the reality is, over time, 80 to 90% of the beta islet cells in the pancreas are destroyed by the body. And so in a healthy patient, this little diagram shown right here, we've got the pancreas producing the green little insulin. It binds glucose and it moves the glucose into the cell. Over on a diabetic condition, you destroy, immunologically, the beta islet cells. You don't produce, or maybe there's only a few green dots. You don't produce any, or you don't produce enough. And so in the funnel cake example, what happened? Well, that patient's immune system was probably destroying the beta islet cells over a 20-year period. Make sense? And so when they were born, maybe they had a functioning beta islet population in their pancreas. By the age of 12, maybe it was operating at like 70%. By the age of 16, maybe it was down to like 45%. And then by the age of 18 or 19, when they had the funnel cake episode, is what I call it, right? FCE, funnel cake episode. The funnel cake episode, maybe the beta islet population was like in the low 30s. So it had almost 70%, he had almost 70% of his beta islet cells destroyed, and then he had 4 or 5 funnel cakes in one sitting. And that was what triggered him to go into a sugar coma. Okay? Hyperglycemia. Now, what are some of the symptoms that result from type 1 diabetes? Well, the 3 Ps, polydipsia, excessive thirst, polyphagia, and polyuria. Polyphagia is excessive eating. Polyuria is large urine production. So excessive thirst, why? Well, if you have high blood glucose levels, you increase the osmolarity, it increases the blood volume, and the hypothalamus is stimulated as the thirst center. Polyphagia, excessive eating, the energy source is compromised. You have lots of sugar, it's just not in the cell. So the body thinks you need to eat. You're essentially starving as an unmanaged type 1 diabetic. You're starving because the nutrition is in your bloodstream, but it won't move from the blood into the cells to be used. So there's plenty of energy, it's just in the wrong location. So you keep eating and you keep drinking, but you can't get enough glucose into the cells. Now, the brain, neuronal tissue, central nervous system runs exclusively on glucose. So you convert other forms of energy to make circulating glucose, right? So it's not like you just have to eat sugar all day long. You can manufacture through gluconeogenesis at the level of the liver. You can take fat and even protein or glycogen and make liberated glucose. And that's why you get those little mid-morning, mid-afternoon peaks, because your body's saying, oh, glucose levels are dropping, I'm going to take my reserves of glycogen, I'm going to break down the glycogen, which is a poly chain of glucose strung together, and I'm going to make more liberated glucose, and I'm going to raise my glucose levels. Because otherwise, Dr. Keller's just going to like fall over in his chair, right? So polydipsia, polyphagia, and then polyuria. Large production of urine because you have sugar in the urine. That's where you get the diabetes mellitus, sweet like honey. The sugar's in the urine because it's not in the cell. That increases the urine osmolarity. Water follows solutes. You lose a lot of water. Okay? Ketoacidosis. Ketoacidosis is the metabolic state of ketone bodies due to the breakdown of fatty acids and the deamination of amino acids. So when you start utilizing alternative fuel sources, you go into a ketoacidosis. And then hyperglycemia, too much sugar in the blood, which I think is fairly obvious. Now we're going to talk about some other organ systems that are influenced in a few slides. But first, before we go there, I want to characterize type 2. So the pathogenesis of type 2. This one's very complicated. It's more common. It's the one that you're going to be wrestling with your patients more likely than type 1. There are some similarities, but the big issue here is a resistance to insulin. In the old days, when I was in college, in the dark ages before there was internet, it's true, I went all the way through college without internet. I feel like we should have a special degree because there was no internet. No? You guys totally disagree? I think there are more expectations of your cohort because of the freedom of information, the access to information that you have. Right? We were just talking at the break. I was like, go to Google Scholar, Google Huntington's plus embryonic stem cells plus Asia. I was like, oh, right on. Like, that would have taken like months to figure that out when I was in school. You could just Google it tonight while you're eating a sandwich. It's pretty awesome. Okay. A healthy sandwich, by the way. Okay. So this is a complicated interaction. A lot of insulin resistance is the problem. In the old days, in the dark, that's where I was going with this. In the dark ages, we used to call this adult onset. Okay? And we would say that it had a very close association with diabetes or with obesity. And obesity and type 2 diabetes do tend to go hand in hand, but there are more and more patients that present with diabetes type 2 that aren't considered to be morbidly obese. Okay, so one of the misnomers is that all patients with diabetes type 2 are obese. That's not true. Okay? Having a patient who is obese increases their risk of developing diabetes type 2, diabetes mellitus type 2. Why? because you're flooding the system constantly with sugar, with glucose. And so as you do that, you release large amounts of insulin. So you have your normal insulin production, right? Just like we saw in the previous slide. Here, you make maybe less insulin than it's depicting, or another option I would draw on the arrow is that you make insulin that maybe is shaped differently than these little kidney bean shapes. Maybe draw them as like circles, so that they're produced and they don't bind. So you either make less or you make a format that you do not utilize. You're resistant to it. Okay, so what you end up doing is trying to make more of it over time, but you just can't. You can't respond. And so the thought process of the insulin resistance is there may be a genetic defect of the insulin receptor itself and or the insulin signaling pathway. So maybe the binding site is compromised, or maybe the pathway of the combined unit doesn't dock with the cell. There's some alteration in its tertiary format once it forms a complex. We don't really know. But what we do know is that the symptoms are aggressive, and the symptoms for type 2 diabetes are not any that become ones that we can ignore. So here I drew this in. I forgot I drew this in. Or the cells become resistant to the produced insulin. Okay? So that would be the secondary pathway. You might draw a little figure here where it looks like a circle instead of like this kidney bean. It has this little binding site spot for the glucose to find a seat. So, the symptoms of type 2 diabetes. Many patients are overweight, they're even obese. We get dyslipidemia, which is an abnormal amount of lipid in the bloodstream. We have hyperinsulinemia, where we have excess levels of insulin in the blood because you're not responding to it. So one way you try to fix that situation is make more of it. Hypertension, right? Too much sugar in the blood raises blood pressure because water follows solute, so you have a higher blood volume. Patients complain of fatigue because the energy is not getting into the cell. And then they generate recurrent infections, like what's shown here. That's a diabetic foot ulcer on the bottom slide. And the problem with the recurrent infections is because the blood flow is compromised at the distal extremities. The blood flow is compromised because we get these sugary lesions that line the inside of the vasculature. The lumen decreases in size. Blood can't move. The first thing that happens before the infection is parathesis. Parathesis is that pinprick feeling, right? Like when your foot goes to sleep. And that is your first indication, that's your nerve's first indication that it's dying, is when it goes to sleep. And it's telling you, it's giving you feedback that you need to reestablish blood flow. And so you move your leg and then kind of do whatever our little trick is that we do, right? And so it's getting your attention that the foot is, that the nerves are dying, you're starving of oxygen. That's parathesis. So limb claudication, which is a fancy word that means pain while walking, or parathesis are side effects in diabetic patients that are very, very common. And what that's a sign of is that the distal blood flow to the feet is being challenged. And you're going to end up with a wound. How does that happen? Well, they step on a carpet tack, or they kick their dresser, or something happens and they get a cut on the bottom of their foot and they can't feel it. And then it won't heal because there's no blood flow. You need blood flow in order to heal wounds. So these are some of the big complications that happen with type 2. And we meaning the healthcare system, spends a ridiculous amount of money treating these symptoms in patients. Okay? And in Flagstaff, we're no exception. So the complications that can occur from diabetes mellitus, and these complications are actually shared. These slides are where we share type 1 and type 2. But the type 1 is shared only if it's unmanaged type 1. So if you know a type 1 diabetic, and they're very good about checking their diabetes, and they're managing it with insulin injections, they're not getting levels of glucose that are high. And so they're not going to present with these kinds of problems. And a type 2 diabetic, really, by definition, is not managing it. That's why they got there. So these shared slides of type 1, unmanaged, and type 2, complicated, or are presenting with symptoms, are shared. So we get these advanced glycosylated end products. What is that fancy word? AGEs. Advanced glycosylated end products are where you got collagen that gets cross-linked by the sugar, and then it forms a lipoprotein accumulation. So the sugar itself cross-links it, forms covalent bonds. It's like you get a sugar-coated protein, and fat will like to stick to that. Okay? One of my pet peeves is when I get in my car and I've got like half-eaten suckers on the floorboard because they stick to everything, right? Because sugar is sticky. And so a advanced glycosylated, meaning you sugar cross-linked it, it sticks fats to the protein. If that's on the inside lining of the bloodstream, then that forms a lesion. Plasma proteins plus the AGEs, they bind to the AGE receptors and they can cause lesions. Protein kinase C activation. If you have high levels of glucose, you activate proangiogenic molecules like VEGF, and this causes what we know as diabetic retinopathy. Right? In the retina, you get an uncontrolled level of new blood vessel growth. It can even cause blindness in these patients if it goes unchecked. So, the pathway known as the polyol pathway, you've got glucose up here, glucose forming an intermediate, sorbitol, sorbitol moving over to fructose, okay? So glucose is high in the bloodstream within the presence of this aldose reductase, this enzyme, you get the sorbitol intermediate, and then this dehydrogenase, sorbitol dehydrogenase, forms fructose. Now you have fructose floating through the bloodstream. Okay, so fructose increases the osmolarity of the blood, and you start getting water accumulation in surrounding tissues as a result of it, and that causes cell injury. So you can cause all sorts of tissue damage as a result of sugar in the form of glucose being high, because eventually through the polyol pathway you lead to excess levels of fructose that cause additional damage. Now, that sugar in the bloodstream, why else is that a problem? Well, the lesions that form on the inside of the bloodstream from those glycosylated end products, they resemble atherosclerotic lesions. The fructose also interferes with red blood cell ability to transport O2. So oxygen won't bind as readily to the red blood cell in the presence of a high osmolarity or a high fructose solution. So you impede the chemistry that takes oxygen, helps it find the iron molecule on hemoglobin and bind. Because now you're trying to do this through a more viscous solution, a solution that's like sugary water. And because it's sugary water and has a higher osmolarity and it's more viscous, it's harder for a gas to move through it. So here's the analogy. Any of you have friends that like sweet tea? Sweet iced tea? How many of you like sweet iced tea? Any of you from Texas? Texas sweet iced tea is like no other place on the planet. It's like 3 parts sugar, 1 part tea. Okay? I had a friend growing up, Cade Kennedy from Texas, and he loved sweet tea, and we would have his mom's chocolate chip cookies and Texas sweet tea. Yeah. And I'm not diabetic, isn't that amazing? And but the sweet tea that they would make, you would put as much sugar into they would make it in Phoenix, and they were obviously transplants from Texas, and they put it out in the backyard, put tea bags in this gallon glass jar out in the sun, so they make it sun tea, and then they would proceed to pour like a bag of sugar into this gallon jar. And they had it down to a science, but it was right before that point where it just started to precipitate out. Right? So you would stir it, you'd add more, you'd stir it, you'd add more, and then if you got to a point where you're like, well, it's not really going into solution anymore, it's like a syrup, then they would just add a little bit of tea from the other jar, right? And then that was perfect. So you cross over that threshold. So imagine that is the situation that we have in our unmanaged diabetics, is you've got so much sugar in the bloodstream that you increase the viscosity, okay? So gas cannot move as readily in that solution. So if O2 can't move as readily, right, we get nerve dying, diabetic neuropathy, because the nerves are not getting oxygenation. Nerves dying, diabetic neuropathy. We get the nephropathy because the kidneys are diseased as a result of the blood vessel disease that we see in the capillaries of the kidney glomeruli. So this vascular disease from this polyol pathway and from these age glycosylated end products causes the kidney glomeruli blood vessels to be compromised. You don't get enough perfusion to the kidney. So now you get kidney disease. And then the vascular disease that targets places like the eye are because you have VEGF being produced. VEGF being produced because of that pathway, protein kinase C activation, due to high levels of sugar. So it's a bad situation for these patients. Okay? Bad situation for these patients. And here's an example of the vasculature and how it's affected. So this is a picture, and it's showing the thickening of the tubular basement membrane in diabetic patients. So, do you see this thick pink border? This is all because of this age glycosylated end products that are causing thickening of that basement membrane. Right? So the thickening of the basement membrane in the vasculature causes, this is of the kidneys, causes compromised blood flow to the kidney. And that's your diabetic renal failure. We get the blindness that happens up in the retina of the eye. We get our, that's also the retinopathies. And then we get our neuropathies, the neurons, because the neurons themselves are starved of blood flow to the distal extremities. And that's where they get the pinprick feeling in their lower limbs. Macrovascularly, the coronary artery disease goes up because you got a high level of low-density lipoprotein that accumulates as a result of that age, that glycosylated end product. Remember, it creates a sticky surface, and the lipoproteins stick to that. And so now you get this vessel disease accumulation in the coronary circulation or in the brain tissue. And so now you increase the risk of developing a stroke or a heart attack. So the diabetic neuropathy, back to this picture, nerve damage because of the polyol pathway, and then the peripheral vascular system, the peripheral nervous system gets compromised because you don't have peripheral blood flow to the distal extremities, and those nerves die. What does that lead to? It leads to lesions that don't heal. They don't feel them as to the same extent that you and I would feel them. They still hurt, but their pain is a little bit numbed as a result of it because of this high glucose content. Compromised vasculature, and then I already told you, this increase in the glucose and ultimately in fructose, or that polyol pathway, impedes red blood cell release of oxygen. The gas doesn't move through that Texas sugar tea very well. So how do we treat? Well, there's a whole list of ways that we treat. I don't want to leave you on a bad note, okay? But this is one of the reasons that type 2 diabetes is such a big health issue in the Western world, okay? Because we're not managing our diets. So if it's type 1, we actually could look at insulin injection. In type 1 diabetics, we monitor their glucose levels. When they get out of whack, they give themselves an injection of insulin, okay, and it works quite well. Why don't we use a pill?
It sits better when it's sitting in the fat.
What's that?
It sits better when it's in your fat.
Well, when it goes into the hypodermic region, it's highly vascularized, so you get uptake. That's exactly right. The hypodermic region is rich in adipose tissue or fat, and it's well vascularized, so you get uptake quickly. If you take a pill, it's difficult on an uptake standpoint, and then a lot of the digestive enzymes will actually neutralize the effect of the insulin. Okay? That's a huge area of research where I do see the opportunity for you all to be using a pill in the future for your patients, not necessarily just hypodermic injections. Type 2, we can use various types of drugs. In fact, in some cases, they can be oral. So we've already crossed over into that oral category for delivering therapeutics for type 2. And also, sometimes we will deliver insulin via injection. I was like, wait a second, why? Well, we might use like a synthetic insulin that's actually more effective, or it's going to respond if the patient is basically non-responsive to the own insulin that they may respond to a synthetic better. Okay? Diet modification is a huge deal. And of course, exercise. Yeah. Exercise and diet. Exercise cures everything, right? No. But the reason that exercise works so well is in exercise, in skeletal muscle, or even in adipose tissue, the adaptation that our bodies go through, here is glucose, here's our insulin receptor, right? And you don't see response of it binding, right? There's no insulin here, the absence of insulin. And so we don't get any uptake of the purple glucose. But over here, GLUT4 is a transmembrane protein that actually is a different mechanistic pathway to bring in glucose into an exercising muscle cell. And GLUT4 receptor expression increases in response to exercise. So in our patients, if we encourage them to exercise, their adipose tissue, as well as their skeletal muscle, will increase GLUT4 transmembrane protein. And this is a non-insulin dependent pathway that will allow glucose to be brought into that tissue. Okay? And then if we're managing the diet as well, and we're trying hard not to have too much sugar in the diet, okay, then we can actually be quite successful in taking care of, I think, a vast majority of type 2 diabetes that gets out of control. Do I think it's going to replace pharmaceuticals? No. But I think this is, a lack of this is what's gotten Western culture into this problem. Okay? Questions over endocrine diseases? Okay, SI sections, please attend. Let me know if you're coming to my office hours or you need another opportunity, another time slot. I'll do my best. And we have our exam 2 next week. Okay? It's very weird to say this on Monday, but have a nice weekend.